Welcome, everyone. I'm Linda Resnick, the Principal Investigator of LeaRRn, and I'm pleased to introduce today's presentation in our series, Using Health Systems Research to Revolutionize Rehabilitation Care. If you would like to enable closed captioning, you have two options in the Zoom navigation bar. You can either select Show Captions if it's visible, or if it's not visible, you can select More to access the closed caption features, and then select Captions, and then you can choose your preferred language. Today's webinar in our LeaRRn series follows a webinar presented by Dr. Anna Baumann, Enhancing Representation Strategies to Engage Diverse Participants in Research Activities. This presentation was recorded and is available on the LeaRRn website, along with our other archived presentations, and you can view all of our archived presentations by using the link in the chat. Our speaker today is Dr. Leo Cabassa, professor at Brown School at Washington University at St. Louis, and co-director of the Center for Mental Health Services at the George Warren Brown School of Social Work at Washington University. Dr. Cabassa is a Puerto Rican social worker, and his research centers on examining physical and mental health inequities in historically marginalized racial and ethnic populations with serious mental illness, such as schizophrenia, major depression, and bipolar disorder. His work blends quantitative and qualitative methods, health disparities research, community engagement, intervention research, and implementation science. Dr. Cabassa's talk will be followed by a question and answer session, and we ask that you please enter your questions in the Q&A feature of Zoom so that we can address them once the talk concludes. And after the presentation, we'll provide a link to an evaluation survey. And we also will be conducting a brief poll to learn a little bit about the participants and who you are today. And we'll conclude the webinar by sharing information about some upcoming LeaRRn events and funding opportunities. So now I'm pleased to introduce Dr. Cabassa to present his talk on equity-grounded implementation science, exemplars from the field. For our attendees, I think, are we going to launch the poll questions first? Great. Thanks. The first question is, what is your familiarity with implementation science? The second, what is your level of familiarity with health equity research? And the third, what is your primary role? And while you're completing that, I'm going to turn this over to Dr. Cabassa to share his slides.
Thank you so much. Good morning, muy buenos días. I'm very excited to be here. Thank you to the LeaRRn Network for this invitation, the opportunity to share our work. Today, we're going to talk about equity-grounded implementation science and some exemplars from the field that we've been doing, and really getting into how we're bringing together health equity and implementation science through the work that we're doing. To begin with, I just had some acknowledgements of this work. This work is funded by multiple sources from NIH and different type of grants. We're also supported by two centers here at Washington University, Center for Dissemination and Implementation, and our newly developed Center for Holistic Interdisciplinary Research in Psychedelics, where one of the new areas of work that we're doing and bringing implementation science to this field. And I do want to acknowledge that this is work that is in collaboration with two wonderful early investigators, Gabriela Nagy at the University of Wisconsin in Milwaukee, and Elliot Rivera Segarra, who's at the Ponce Health Sciences University in Puerto Rico. And this is a work of collaboration that we've done over the past year or so. They're also implementation research scientists in training, which has been great. So to begin with, I want to start with a clear definition of what we mean by health equity. And we take sort of Braveman's definition that health equity means that everyone has a fair and just opportunity to be as healthy as possible. And this requires removing obstacles and barriers to health, focusing on issues like poverty, discrimination, lack of access to good jobs, and access to high quality healthcare. One point we want to make here, and actually I'm glad that I'm following Anna Bauman, a great colleague here at WashU, that for us and the work that we've done together is that health equity is not an outcome in itself. Actually, health equity, in the way that we're going to talk about it, is a process. Health equity requires continuous action and attention to address historical and contemporary injustices and to allocate resources according to those needs. So I just want you to understand that what we're talking about is a process, and how do we disentangle this process and embed it within the work that we're doing in implementation science. I love pictures, so one way to think about equity is this great picture from the Roy Wood Johnson Foundation of the differences between equality and equity. We're not talking about equality. That's not what I'm interested in talking about, and actually what our work doesn't focus on equality. Equality, as you can see here, is providing everyone the same thing without considering their specific needs, their circumstances, their capabilities. Equity, on the other hand, as you can see here, focuses on providing people, and you can think about this in multiple levels, people, organizations, clinic, community, what they need to be successful based on their unique needs and capabilities. So in equity research and the work that we do is how one size does not fit all to address health equity. We may need to do different things. We may need to tailor our approaches, intervention, implementation strategy to address the complex determinants that shape healthcare disparity. So one of the ways that we bring this work is using that equity lens that forces us to ask about these differences very explicitly and begin to tackle the unique needs that people have to address their needs and hopefully improve their well-being. So to set the stage, why do we need to integrate health equity research and implementation science? And we'll go through these points in more depth, but really there's an impetus here. One of it, sadly to say, is that inequities in health and healthcare continue to persist, continue to increase, and the translation of evidence into practice it takes longer in historically minoritized communities. And most of my work is in the United States, so focusing on those communities. There's also a need to move beyond documenting inequities. It's great to understand them, but we need to start focusing on how do we go about eradicating these inequities. And implementation science can provide a pathway to those tangible solutions. Implementation science, as you can see, have argued for an increased focus on health inequities. Although this is a more recent discussion in the field, and I'll show you some data that we have found around it. There's been sort of an upsurge of this discussion during the COVID-19 pandemic and after the murder of George Floyd and the racial reckoning that have happened in this country. And then there's numerous calls to actions to date, but this, as you will see, largely remain aspirational and theoretical. And we wanted part of the work that we're trying to do is how do we that are doing this work, how do we doing that and show examples, concrete examples of how we bring these two fields together. This idea of merging and blending implementation science and health equity is not new. There's been many others that have done so. And here's some examples of people that have coined this term or looking at it. And even more, this is from a presentation that Anna and I did in 2023. Actually, there's if you follow implementation science, we love frameworks, and God knows we have plenty of frameworks to inform the field. So there's also been an explosion of frameworks that focus explicitly in focus on equity. And I'm using the word very clearly here. These are frameworks, not theories. We implement in implementation science, we actually need to move beyond frameworks and start working on testing theories. Do they work? Do they predict anything? So these are some of the initial components I have out there. But when we looked at this literature, actually, this is a figure developed by Gabriela Nagy, that this is not, implementation science has not paid attention to health equity from the very beginning. This increase on attention to health equity is actually a more recent phenomenon. And as you can see here, we did a very high level PubMed search of looking at words like equity, implementation science, health disparity, health equity, and we examined like 3,000 articles that are published since 1997. And then we layer on top of that historical events in the field. And as you can see here, the numbers of articles published from 1997 until the 2010s encompass only a handful of papers per year, some of it that from our group. And many implementation science journals and other journals were actually not publishing this type of work, and it wasn't what they were tending to do. Second, we see a larger increase published as the field begins to move, as more conferences begin to happen, as the implementation research training programs begin to approach, as grants such as this begin to get funded. You see then a more increase in this type of work. And then there's an acceleration happening, particularly after 2020, where there's almost a doubling, more than a doubling of these papers in the literature. But one of the things that caught our attention as being health equity researchers that do implementation science and that we live between these two worlds is that many of the papers that are being published were most aspirational. So calls to actions, recommendations on how to do things, frameworks of how do we embed health equity. And we really felt that there was a need to understand how do you actually do this? And the people who are actually doing this work and blending these two fields, what are their practices? What do they do? And how do they embed this in their work? So we wanted to write about that and provide some examples from our own work. And that's what we'll be doing today. So to make the case for why we need this equity ground implementation science, one, as I mentioned, inequities in mental health care, which is the area of work that I do, continue to persist. This is a long-standing issue, and some recent national data looking at service use, trends in racial and ethnic disparities in adults' mental health treatment use from 2005 to 2009. What we see is that these inequities continue to persist. We see here examples of between non-Hispanic whites and Hispanics, and other than in major past service use in major depression that has narrowed that gap, the gap continues to exist. And it's even more troublesome when you look at past service use for serious mental illness, where you see this gap basically stay flat over the years. And this is very concerning because inequities in mental health care contribute to greater persistence, severity, and burden of mental disorders. So this is a major issue that impacts the lives and families and communities impacted by these inequities. The other component that we saw in the research is the underrepresentation of minority population in clinical trials. This continues, and there's a great paper that was published in 2022. They looked at 20,000 US-based clinical trials that have reported results in clinicaltrials.gov. And one finding here that I'm not presenting, but you'll tell you, is that of those 20,000 trials, less than half, 43% reported the race and ethnicity of their participants. The other major finding is that you see that whites, non-Hispanic whites, are overrepresented compared to their population representation, and that every other minoritized group is underrepresented in the clinical trials, and this continues actually to impact the science. Why is this important? We've also documented this underrepresentation in not only clinical trials, but effectiveness trials in the area of the physical health people with serious mental illness. And as we have presented before, the exclusion of historically underserved communities in clinical trial creates serious blind spot, not only for the treatment science, but most importantly, in moving that science into practice. If we don't have the evidence to make sure that these treatments are actually appropriate, safe, effective with minoritized communities, how are we going to know? So this is a huge area that requires, and actually Anna's presentation talked a lot about how do we address this major component. But this is not only from the side of implementation science, from the health equity researchers. In our view, there hasn't been sufficiently incorporated implementation science into their work. There's this dangerous assumptions that we see in the health equity world. Well, there's this idea that all you need to do is culturally adapt interventions, and that will fix the problem. That's actually not true and requires more work. There's also this idea of getting stuck in the efficacy and effectiveness loop. This is something that LeaRRn talked about in 2019, which focuses on testing intervention in historically minoritized communities, focusing on whether they work, the effectiveness of it, without getting to the actual implementation, moving the science into practice. And that's something that we need more investment. And the National Institute of Health right now have several initiatives out there where they're moving this forward. So there's some movement in getting out of this efficacy effectiveness loop and actually thinking about implementation. And then last is a major assumption in the field that one size fits all, just scale up intervention and it will improve the quality for everyone. And based on our definition of health equity, that actually is not going to work. We can scale up intervention, improve access, but we also need to pay attention of whether these interventions are appropriate, how to make them more culturally appropriate, and how to make these interventions more effective in minoritized communities. And then lastly, one thing that is critical is that implementation science and health equity research actually share some common goals. If you look at sort of at the heart of this particular fields, both fields are focusing on improving the quality and outcomes of services. It's really around addressing this gap between need and service. Both fields try to make treatment more generalizable, so that they can be used in routine practice settings. And both fields actually has a long history of emphasizing contextual factors. Think about multi-level approaches to address this. So this is why there's a good marriage and blending of these fields. They are really complementary with each other if we work on them very clearly and we bring them together. So for our perspective, our approach for equity-grounded science, implementation science, is an approach that blends elements of health equity research and implementation science. And our foundations as health equity scholars is rooted in questions of health and healthcare equity. In fact, we actually are pushing back this idea that health equity is a special case in implementation science, that you only do this if you're working with certain communities. And in our view, it's actually health equity needs to be at the heart of implementation science if we want to achieve the goals of improving care, making services more generalizable, and addressing the needs of communities. So this is the bedrock of our work, and it allows us to delve into critical inquiries surrounding the reach, the impact, the sustainability of evidence-based intervention that may be effective, but regrettably have eluded accessibility and benefit for the very communities most in need. So we place equity at the heart of our research, and we affirm that it is not a peripheral consideration, but an integral part of our scientific pursuit. As part of this. So we wanted to sort of present this and define it and then show how we're doing this. So, and this work actually, it's about to come out in a paper in Psychological Services, a special issue on health disparity and implementation science, and we were very fortunate to be able to publish that. And in that paper, we have a case study basically of 3 different studies that actually blend this, and these are from both Gabi, Nagy, Elios Rivera Segarra, and myself. And these are 3 studies that are blending this. One is Cultivating Resilience, which is a pilot randomized controlled trial aiming to examine the feasibility, acceptability, and preliminary clinical impact of cultivating resilience, cultivando fortaleza. And it's a study about first and second generation Latino and Latina adults, particularly in Milwaukee. And it's a randomized trial, and they're really looking at how to deliver this intervention in community settings. The second study is a stigma reduction training for medical students in Puerto Rico. The idea was to develop and pilot test a really innovative mental health stigma behavior reducing intervention for medical students. Lots of stigmatization happened from healthcare providers. So this particular intervention really developed a really innovative video-based and practice-based approach for helping medical students to have less stigmatizing conversations and interaction with people with serious mental illness and other conditions. And this is actually being implemented in one medical school in Puerto Rico. And then lastly, the work that I've been doing is to test the effectiveness of a healthy lifestyle intervention for people with serious mental illness who are overweight or obese. And we'll talk a little bit more in detail about this particular study and how we're blending implementation science and health equity research in this particular component. And actually, the whole impetus of this study that we conducted was actually blending that from the very beginning. And it was part of how we wrote our grant. This is a study that was funded by the National Institute of Mental Health as an R01 several years ago. So to put this more into action and examples, this actually comes from a trajectory of projects. We in the literature, you sort of might find the randomized controlled trial, the result, but there's a whole history behind those studies. And in our case, we actually started the study with a photo voice component. We actually went to the communities, to the supportive housing agencies, and learned about what were the needs from the client's perspective and understanding what will they want from this intervention. And photo voice was really important. It's a participatory method that uses cameras and dialogues to come together, to people to come together and generate community knowledge to inform the implementation. And that study was very powerful because it showed us that it generated really critical information about the client's preference for health intervention. This is all in supportive housing agency for people with serious mental illness. And it showed us three major things. One, what is the type of format of the intervention to address their physical health needs? And people were very clear about, we want a peer-based intervention. We want people that have lived experiences with serious mental illness and chronic medical conditions to be the ones delivering the intervention. Don't bring professionals here to lecture us and tell us what to do. We want people that actually have done it. So that actually gave us a really important component of the intervention needed to be peer-based from the very beginning. The other component is the content of the intervention. People wanted things around weight loss, physical activity, things that we all need to improve our physical health. This population really wanted to focus on those components. And then they wanted the methods of the intervention. They didn't want us to be lecturing and telling them what to do, but actually provide an intervention that has experiential learning, learn by doing, acquire some skills in cooking, in exercise, within their community, in their context. So these participatory methods is one approach that we brought health equity to understand what are the preferences that the clients want and help us then identify an evidence-based approach that we can then adapt to this particular setting and this particular population. So we ended up actually adapting the group lifestyle balance, which comes from the diabetes prevention program, a well-established evidence-based practice, but it hadn't been done for people with serious mental illness in supportive housing by peers. So we had to do major adaptation on that. And this is a well-known healthy lifestyle intervention, uses behavioral techniques. We train, and in our case, it was delivered and trained by peer specialists, people with lived experiences with serious mental illness and obesity. This is an intensive intervention. It takes 12 months of intervention, 12 weekly core sessions, 4 bi-weekly transition session, and then 6 months of monthly maintenance session. And it's a lot of engagement. There's a lot of to-do and work at home and a lot of contacts in between sessions for it. And what we did, we adapted it, and then we tested it in what we call the peer-led healthy lifestyle program in supportive housing, which is a hybrid one implementation study. As you can see here, there are different phases here. We had a phase one implementation phase where we actually wanted to learn about the context of practice before we implemented anything, before we did our effectiveness trial. We really wanted to understand the context of the supportive housing agencies and understand how they do physical health issues, how do they do healthcare, what are the challenges. And all super important to understand that context. Then we used that information and conducted a large clinical effectiveness trial with 314 adults with serious mental illness and a BMI of 25 or above. We compare our intervention to usual care. We did assessment at baseline, 6 and 12 months, and then 18 months for follow-up. And then we had ongoing fidelity monitoring. And then we went back and did another phase of the implementation study to see how the context has actually changed. And this is something that we really miss when we intervene in a particular organization, agency. We're actually changing the context with our presence and our research there. So we wanted to understand how that context actually shifted throughout our study, and also to understand what these agencies are learning. And that was extremely helpful for our study as well. So blending sort of testing and intervention, but also understanding the context. And as you can see here, we're overlaying sort of a mixed method study on top of an effectiveness trial to do that. So what were some very specific components that we did around the health equity component? So in the elements of our peer-led healthy lifestyle program, there were several things that were very practical and are central to health equity research. One, we had a steering committee composed of the research team and representatives from each of the 3 housing agencies that provided full oversight of the entire study. We met monthly. They provided input into our methodology, our approaches, our recruitment strategy, the content of our intervention. And that was extremely important to understand the people who are delivering this intervention to be part of our research team and have this collaboration and partnership. Our actual intervention was developed with input from participants and the peer specialists. We went through a whole process of adaptation, and actually part of this process was they were delivering the intervention, and then we were learning from them and making small adaptations as we went along as well. And that was very important to ground our interventions on the people's needs and the context of practice. One component that we did here for health equity is that we brought these interventions to people's doorsteps. One of the key components here is that we wanted to bring this intervention to housing agency where people live, so that we address all the access barriers, transportation issues, engagement issues. So we brought the intervention to them, to people's doorsteps, to people's homes. And supportive housing agencies is a great place to do this, since this is where people are living. And it helped us with the engagement. And then we enroll mostly Black and Latino participants. This is actually one of the few studies, sadly enough to say, that has done this, that has the majority of the population, of the participants, come from minoritized community, mostly Black and Latino participants. 82% of our sample come from this community. And when we wrote this grant, that was one of the major arguments we made, that this whole literature has a lot of intervention, but it excluded and did not enroll Black and Latinx participants. So we wanted to make a concerted effort to do that, and we achieved that. From the implementation side of things, we collected implementation outcomes. So not only were we interested in understanding, does this intervention work, but we also wanted to understand, how does it work? Is it acceptable to the participants, to the settings, to the peer specialists, to the clinicians in the setting, and also tracking the fidelity of the intervention, which is really important to understand how the intervention is working and whether it's being delivered as intended for the population. As I mentioned, we use a longitudinal mixed method approach to examine how changes in context influence the intervention affecting the implementation. And this actually was really important for our study because during our intervention, we had sort of the implementation of the Affordable Care Act, both in New York and in Philadelphia, and a lot of different changes in the healthcare system while we were conducting our study. And by collecting this mixed method data, we were able to see how those policy changes and how agencies were implementing those policy changes actually influences our trial. One example for that is, for example, usual care, which is our comparison condition, really shifted during this time. There was more attention to the physical health of these residents because there was more money, more funds, more resources available for this agency to do that. So we had some issues with that, and I'm happy to talk about that in the Q&A. It also helps us understand the context, how it's changing, and how intervention was embedded with that as well. And then we use qualitative data to examine potentials for sustainability. That actually came from our steering committee at the end of our trial in the last year, when we asked them, so what would you like us to leave with? What would you like us to do? They're like, you know what? We would like sustainability plan. This grant is about to end. How can we sustain elements of the work that we've been doing for 5 years? So we did this great study on understanding the sustainability and develop sustainability plans for each of our 3 supportive housing agencies that they could then implement without the research dollars and funds that we had provided. And I thought that was a really important component, and we use research to provide a space and a time to talk about sustainability in each of the study sites as a part of our implementation science component. So in terms of operationalizing our approach to equity-grounded implementation science, sorry, my Spanish there got in the way, we wanted to really play around sort of this component. The health equity research piece of this is that we focus on reducing health and healthcare inequity. As I mentioned, this is not a peripheral component or a special case. We do studies exactly on this topic and really understanding those elements and beginning to identify the social drivers of health. We apply from the very beginning community engaged methods, steering committees, community advisory boards, using participatory methods for that, and approaches for that. Ooh, my thing just went a little bit haywire. Okay. Can you see my slide? Something shifted here.
Yes, we're fine. We're
Oh,
still
okay.
seeing.
Something happened for my, okay. Then this, the other component was that our work also emanates from our personal commitment and our professional commitment to addressing health equity and understanding the needs that we need, and that helps drive our approach to science. The equity ground implementation components, it's about situating the interventions in the community, research out in the community. We want to be where people are at to address all the access and issues that come up with this work. We want to co-design interventions, so really thinking about implementing and developing something, adapting something with the end in mind, so that the interventions can actually be used once the research dollars are done. And then we weave through our process mixed methodologies and community engaged methods through our work. And then from the implementation science, the design for implementation approach, adapt to the socio-ecological systems perspective, so looking at things at multi-level. Employ hybrid studies. As you can see here, we did most of the studies that we have in this paper are hybrid one, but thinking about studies that can do both effectiveness and implementation in the same design. And then lastly, assembling a multidisciplinary team. This is very crucial for this work, understanding the expertise. I'm a social worker, but our team had social workers, had psychiatrists, had medical doctors, had anthropologists, sociologists, all of those, and also the perspective of the community as another set of experts. Community members, peer specialists, bring their own set of wisdom, their own expertise, that we need to then blend it with our scientific expertise and come together with that. And that's a really important aspect of putting these things together. The expertise, there's different sources of knowledge that can come together to address these inequities. All right. And then some concluding thoughts as we're putting this together. One, in this paper, most of the studies are heavily on hybrid one study, which hybrid ones just for the audience, focus on testing and intervention, understanding the effectiveness. That's the aim of the study. And then secondarily to examine the implementation, like what we did, understanding context, but the heart of our study is actually testing, does the intervention work in this setting with these providers? We need more work that move from hybrid to different types of hybrid design, particularly hybrid 2, where you have a dual emphasis on effectiveness and testing implementation strategies, and then hybrid 3, which is all focused on addressing testing implementation strategies and secondary examining effectiveness. The studies that we talked about were mostly for Latino and Black populations in the United States and in Puerto Rico. We need more examples of how these approaches may or may not work with other minoritized groups in the United States and other areas, in particular in Latin America. Our study focused mostly on adults. Each of our studies are adult population of 18 years and older. We may need examples of how to apply these principles and actions with children, adolescents, and families, a really important area of work. Our study focused primarily on mental health outcome. Each of those examine this type of outcome. We need examples on other types of health and healthcare inequities. And then our studies focus largely on prevention and health promotion. We need examples of studies like this that are testing clinical interventions. And there are several studies out there in the field right now that are doing this type of work and can show sort of those components and those ideas for where we're going with this. And then if you're interested in more, as I mentioned, this paper is coming out in Psychological Services as part of a special issue on implementation science. We're very lucky to be able to share this work. And this is being led by Gabriela Nagy and Elio Rivera Segarra as great collaborators. We also wanted to share with everyone a set of recommended reading. This is not an exhaustive list. This is just curated from our own experiences. But we wanted to show some publications that are out there that have been pushing these ideas and have been really thinking about the combination of implementation science and health equity work in different components and stuff like that. The work by Kelly Ashberger is a wonderful example of some of that work. The work by Anna Baumann, who's been a presenter here, has been really at the forefront of pushing this forward. Shinman as well, and Steve Bartels and team as well have done a great work in this. And so these are some of the publications that are out there. I know this is being recorded so people can look at the slides, and we provided sort of the full references for this. There's a lot here. I know it was five slides here. So we can end here, and I'm happy to take more questions. We have plenty of time for questions, which is great. And we would love to hear any reflections or questions that you have. This is our contact information, and we are all doing very different work, so it would be great to engage in a conversation around these topics and potential next steps as we move forward. So thank you so much for this opportunity, and I look forward to your question and the discussion that we'll have.